Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute myeloid leukemia with KMT2A rearrangement. This is an acute myeloid leukemia that is characterized by fusion of KMT2A gene with any of number of fusion partners. It accounts for only 2 to 3% of acute myeloid leukemia cases in adults. However, in children, it is the most common genetic abnormality, accounting for about 20% of all acute myeloid leukemia cases, with the frequency being or exceeding 50% in infants. In adults, they can present with either leukopenia or leukocytosis. However, in children, most cases present with hyperleukocytosis. Extramedullary involvement manifesting as gingival hypertrophy or skin lesions is common in this acute myeloid leukemia. Morphologically, we can see variable blast morphology, with most cases having monocytic, monoblastic, or myelomonocytic features. And in children, especially when you see KMT2A fused with MLLT3 or MLLT10, it can present as acute megakaryoblast leukemia. Now, let me share with you this case with a 45-year-old male who presented with 3-week history of gingival swelling and pain and was found to have leukocytosis. Now, as you can see here in this peripheral blood smear, let me go high power. And I do see a number of large cells, and these cells are large when we compare them to the surrounding red blood cells. Let me go high power on these cells. Like, for example, this cell here in the middle. Let me get in focus. We do see this large cell, high nuclear to cytoplasmic ratio, moderate amount of cytoplasm, and folded nucleus. This one here is a blast. Here in this field, I do see 3 blasts. They have large nuclear, they have high nuclear to cytoplasmic ratio, they have large nuclei, they do have prominent nucleoli, like for example, this one here is a prominent nucleolus, and this one here is a prominent nucleolus, and they have scant amount of cytoplasm. I don't see any visible granules in these blasts. Let's go around and see if we can see more. This cell here is a blast. And this cell here is a blast as well, with folded nucleus that is subtle. And I do see some small, tiny granules. Let me go around more. This cell here is a blast, while this cell here is a lymphocyte. And you can appreciate the difference. The blast is much bigger. The chromatin here is open, while the chromatin here is clumped. And this blast here has prominent nucleoli, like this nucleolus here, this nucleolus here, and this nucleolus here as well. Here in this field, I do see 1, 2, 3, 4 blasts. So as you can see in this peripheral blood smear, we do see a lot of blasts. And then upon counting 100 white blood cells, we ended up counting 66% blasts in the peripheral blood of this patient. Now, let me show you the bone marrow aspirate smear. I'm looking for a part that has bone marrow spicules. And here, this is the speculated part of this bone marrow. And even from this power here, I do see a lot of large cells. Let's go high power. Let me go even higher power. And as you can see here, I do see a lot of cells with high nuclear to cytoplasmic ratio. They have large nuclei and they have a very small amount of cytoplasm. So all these cells here, or most of these cells here that are large with the prominent nucleoli are blasts. Here in this field, this is a blast here. This is a blast as well. This cell is a blast as well. These here are blasts. Here as well, we do see these cells with large nuclei. Some of them have prominent nucleoli. Some of them are folded or indented like this one here. So we do see sheets of blasts in this bone marrow aspirate smear. Now, let's have a look at the core biopsy for this patient. Let me get in focus. And as you can see here, this bone marrow biopsy is markedly hypercellular. We said that the patient is 45. The cellularity that I would expect for such a patient would be between 50% and 60%. However, the cellularity here is over 90%, or you could say over 95%. What I see here is these sheets of cells. Let me go high power. Here we do see sheets of cells. They are large. They have prominent nucleoli. Like this is a nucleolus here. These two nucleoli here. Two nucleoli here as well. And then some of them are indented, like this one here. Some of them show nuclear folding, like this one here, for example. And all of these cells here are blasts. Going around, all of these cells here are blasts. Now, let me take you back to our presentation. So we said the blast morphology, most cases have monocytic or monoblastic or monomonocytic features. And in children, when they have fusion with MLL-T3 and MLL-T10, they can present as acute megakaryoblast leukemia. As for the immunophenotype for this leukemia, it's pretty variable, with most cases being CD33 positive, HLA-DR positive, CD65 positive, and lysozyme positive. CD34 and CD117 expression depends on the subtype. If it's monocytic, it's more likely to be negative, for example. Now, let's have a look at the flow cytometric findings of our patient. So, as you can see here, we do see our lymphocyte population in green, few monocytes in yellow, few granulocytes in blue, and a very big dim CD45 population in red and brown. This population is predominantly CD34 negative, with very few cells showing CD34 positivity. The T cell or the T lymphoid markers are negative, including CD2, CD3, CD5, and CD7. Here we see CD19, which is a B cell lymphoid marker that is negative, and CD56 is negative as well. This is our B cell tube. CD19 is negative, CD20 is negative, CD10 is negative in these blasts, and CD38 is dim. Now here, this is our myeloid tube. CD33 is positive, CD13 is positive, and CD117 is dim. CD123 is positive in almost all of the cells, and this is important because CD123 can be targeted by targeted therapy. HLA-DR is negative, and CD7 is negative. Yeah, here our CD123 is positive in about 99.70% of our cases, of our blasts. And here, this is our monocytic tube. Our blast population is negative for monocytic markers, including CD11b, CD14, CD16, and CD64 is positive in most of the blasts in our population here. However, CD14 is the most specific monocytic marker and it's negative in this case. And lastly, here, our blast population is predominantly MPO negative, with some blasts showing positivity. However, TDT is negative, CD79A is negative. So the summary of this immunophenotype, we have a CD34 HLA-DR negative population, dim CD45 that is positive for some myeloid markers, including CD13, CD33, and partially or dim positivity for CD117. Now, let's go back to our presentation. The molecular findings in this acute leukemia include multiple fusion partners with KMT2A. Out of these fusion partners, MLL-T3 is the most common one to be identified. One of the important points that you need to consider is the presence of the translocation of KMT2A with CREB-BP. And this fusion is important because patients with this fusion here or this fusion has been observed in patients who underwent treatment with topoisomerase II inhibitors, and the presence of this translocation is considered presumptive evidence and should prompt consideration and a careful search for a history of malignancy and cytotoxic therapy. The essential criteria that you need to make this diagnosis include identifying a myeloid neoplasm with increased blasts or the presence of myeloid sarcoma as well. As for the blast percentage, they don't have to be more than 20% in the peripheral blood or in the bone marrow. These blasts should express a myeloid phenotype. You need the presence of KMT2A rearrangement in a patient with acute leukemia not fulfilling immunophenotypic criteria for mixed phenotype acute leukemia or fulfilling criteria of myeloid neoplasm post-cytotoxic therapy. A desirable criteria is the identification of the KMT2A fusion partner, and the prognostic impact depends on the fusion partner. However, the overall prognosis is poor in this leukemia. This is the end of this video. I'll see you next time.